Hi, everyone. Welcome to Breaking the Science, a podcast produced by Angels Protection Inc., where we amplify the voices that challenge inequity, advance health justice, and reimagine what care can look like when dignity and truth are centered. I'm your host, Makaila Davis, founder and chairwoman of Angels Protection Inc. And today's episode is a part of our Men in Medicine series, where we spotlight men in healthcare who are not only leaders in their fields, but advocates, those who live their expertise, influence, and platforms to confront disparities and push medicine forward in service and equity. Today's conversation is not just about medicine, it's about women's health, it's about race, it's about informed consent, and it's about the cost of silence. So I'm really looking forward to our guest today, Dr. John Lipman. He's a board certified interventional radiologist and a nationally recognized authority in the non surgical treatment of uterine fibroids. But beyond his credentials, he's a physician who's made equity, not convenience, the center of his life's work. Dr. Lipman earned his medical training at Georgetown University School of Medicine and completed his residency at Brigham and Women's Hospital at Harvard Medical School. Followed by a fellowship in vascular and interventional radiology at Yale, New Haven Hospital, he has achieved fellowship status in both the American College of Radiology and the Society of Interventional Radiology, an honor earned by fewer than 10% of radiologists nationwide. He's delivered more than 200 invited lectures at some of the most prestigious medical institutions in the country, served as president of the Southeastern Angiographic Society, and founded the Atlanta Fibroid Center, a world-class facility dedicated exclusively to non-surgical fibroid care. But what makes Dr. Littman's voice especially important today is this. He's refused to accept a system where women, particularly Black women, are not told all of their options. So I just want to thank you so much, Dr. Littman, for joining the podcast today.
Oh, I appreciate you having me. Thank you.
So I kind of wanted to start this conversation off a little bit by asking, what first drew you to interventional radiology, and when did uterine fibroids become a central focus of your career?
Well, interventional radiology is a subspecialty of diagnostic radiology. It uses radiology imaging to guide care all over the body. We can now gain access to the body in a number of different ways and treat all sorts of different conditions that used to be treated by traditional surgery. Now that surgery can be completely replaced with a non-surgical procedure. And in the case of fibroids, non-surgical outpatient procedure called uterine fibroid embolization. So it's image guided medicine. It's cutting edge without the cutting, whatever you want to call it. It's not surgical, but we can go anywhere in the body and treat all sorts of conditions. My particular expertise, as you mentioned, is the non-surgical treatment of uterine fibroids. So the traditional way to treat fibroids, unfortunately, the medicine is not very good for fibroids. So the medical therapy often fails, sometimes fails pretty quickly. And so it then transitions into surgical options, which there are basically two main surgical treatment options. And it depends entirely on a woman's desire for fertility, which of those two she gets offered. If she says, I have no interest in fertility, she gets offered a hysterectomy. If she has an interest in fertility, either definitely or possibly, she gets offered a myomectomy, which is surgically cutting into her, cutting out some of the fibroids, which is one of the biggest problems of myomectomy, a very high recurrence rate, because they never get them all out. Cutting into her, cutting out some of the fibroids, sewing the uterus back together. Hopefully, some end up with a hysterectomy, but sewing the uterus back together, hopefully successfully, and then sewing her back together. We offer a non-surgical procedure called uterine fibroid embolization, or UFE. It's a 30-minute outpatient procedure where patients go home not only with their uterus, with just a Band-Aid and a brief recovery. They get the relief of symptoms they're looking for. That's tremendous, high success rate. They avoid the risks and long recovery of surgery. That's really important. And importantly, and often underappreciated by a lot of physicians, they get to keep their uterus. The uterus is really important to women, even those women that are not interested in children.
No, I really appreciate that. And you like starting off in a deep dive. So, like, what I'm hearing is that, like, depending on her responses to her physician, that could make a big decision in her next steps with her healthcare.
Right. I mean, women that are suffering with fibroids cause a lot of symptoms. They're hard and firm. They're like rocks. And so they press on whatever is next to them. So fibroids are categorized by their location in the uterus. The most common type of fibroids are the intramural fibroids. Those are in the muscle, the meat of the uterus, which makes up 95% of the entire uterus. So the intramural are the most common type. The second type are fibroids that are located just under the lining of the uterus, which is what sheds, which is responsible for a woman's period. They're called the submucosal fibroids. They cause the heavy bleeding. Fibroids are the number one reason why women have heavy periods, and it's from these submucosal fibroids primarily. Then there is the third type of fibroid that are on the outer edge. They're out in the suburbs. The cavity of the uterus is downtown, submucosal right up against the lining, intramural in the meat, and then the ones out in the suburbs, the subserosal fibroids, they grow away from the uterus and press on whatever happens to be next to them. If they're next to the bladder, they press on the bladder to cause urinary frequency and waking up at night. If it's toward the back of the uterus, it can press on the colon to cause constipation. If it's laterally, it can press on pelvic nerves to cause pelvic pain. Sciatica, the same pain that you get from throwing out your back, you can get from fibroids. If it's near the cervix, it can cause painful intercourse. Those are the different types of fibroids. The intramural, depending on which way they grow, if they grow towards downtown, towards where the lining is, they can act like the submucosal variety and cause heavy bleeding. If they grow outwardly toward the subserosal ones, they do more of the bulk related symptoms, or they could grow so big they grow in both directions and cause bleeding and bulk symptoms. So, fibroids are the number one reason why women have heavy periods. So, that's usually the presenting symptom to their gynecologist.
Okay, that makes sense. And then also like to like tie into like as a male physician advocating so strongly for women's reproductive health, what personal or professional experiences shape that commitment?
Well, now that I've been treating fibroids non surgically for almost 30 years now, just about 30 years, with this tremendous UFE procedure, which is available throughout the country and has been available for about 30 years. But this is all I do. It's my life's work. I don't do anything else. Um, and it's such a transformational story when you treat women that have been suffering with these crime scene like periods and significant pain month after month after month. These women are oftentimes profoundly anemic because they've lost so much blood month after month that they can't possibly replace. They become anemic. So they're tired, they're fatigued, they're worn out, and they're suffering with pain month after month. And to transform them with a simple outpatient 30-minute procedure and give them their entire life back, give them their energy back, give them their quality of life back that they haven't seen in a long, long time. It's the fuel that keeps me going to work every day. Um, I just returned from my 40th medical school reunion, and most of my classmates are retired. And they're asking me, well, why are you still working? I love what I do. Um, when you can transform women's lives like that with such a simple procedure, I mean, I hope I can continue to do this for years to come. It is the fuel and it is my life's work, and it's very, very gratifying. And I feel very privileged that I can care for these women. And our main message is no matter what your gynecologist tells you, you don't have to have a hysterectomy for fibroids. Fibroids are benign tumors, they're not cancerous. It's the number one reason why women get hysterectomies, unfortunately. And just to throw out a few numbers, hysterectomy is the second most common surgery performed in the United States, which is staggering because half the population and half the people on this conversation don't even have a uterus. It's the number two surgery, and the average age of women undergoing hysterectomy is less than 40. And I've met way too many women, less than 30, have already had hysterectomy for benign fibroids. None of those women wanted it, but they were suffering so badly and didn't know about UFE. They weren't told about it by their doctors that they gave in and had the hysterectomy. And having a hysterectomy at any age for fibroids is tragic, but it is particularly tragic for young women because it changes you. Undergoing a hysterectomy can change you psychologically, like a man being castrated. It can change you sexually, loss of libido, loss of orgasm. There's a lot of bone loss after hysterectomy, a lot of urinary leaking. Next time you go to a Kroger, Publix, grocery store, drugstore, wherever they sell adult diapers, take a look at who's on the package. Who I think should be on the package of an adult diaper is a very elderly man or a very elderly woman. You won't see that. You'll see a young African American woman on the package. Why? Because they're the number one target for adult diapers. And these are, say, young women, women in their 30s, maybe 40s. They've had a hysterectomy for fibroids, and now they need to wear an adult diaper for their life. It's tragic and completely and totally unnecessary.
No, I really appreciate that point too, that they can get this procedure that takes 30 minutes
30 minutes.
versus a
They go
whole.
home in about 3 or 4 hours recovery at our center at the Atlanta Fibroid Center. And they have a brief recovery at home. The recovery after surgery, they're in the hospital, first of all. And then when they do end up going home, the recovery is 6 to 8 weeks, usually closer to 8 than 6. The recovery, our patients go home the same day. They're in bed or couch that afternoon or evening. And the next morning, they're up and mobile. They're moving about, walking around, feeding themselves, going to the bathroom themselves. They have a Band-Aid at the top of their right leg where we went in. The recovery is a matter of a few days, not weeks or even months with surgery. And they get to keep all their parts,
And
even
that's
have
the main,
children.
and that's the main part, being able to like keep your reproductive system and still be able to bear children. Um,
Yes.
because sometimes there might be a moment where you're like, oh, I don't want to have children right now, but then you don't know how you're going to feel in a year from then or 2 years, and
Right.
it might change. So,
Well, we had a patient who was in her late 30s, 38, 39, and I saw her a long time ago, but I remember there are certain patients you just never forget. And she came into my office and she had all the symptoms, horrific bleeding, pelvic pain every month. It was really draining her. And she went to her gynecologist, and the gynecologist said, well, you need a hysterectomy. And she was like kind of taken aback. And she's like, hysterectomy? I'm not sure I'm ready for hysterectomy. And he's like, I don't understand. Why are you so reluctant? That'll end your fibroid problem. And she's like, well, I don't know. I might be interested in having a child one day. And he said, well, you're 38, 39, almost 40. You're single. That ship has sailed. And she was so upset by it, understandably so. And I said, oh, I am so sorry. I had to apologize about a physician. I didn't even know who it was. That was such an inappropriate, crass thing to say. And I said, I don't know if you'll have a child, but what I do know is I can help you. And let's start there. And she underwent the UFE procedure. Her life was transformed from horrific periods in pain to no pain, normal periods. She did just like the vast majority of our patients do. She did really, really well. And then she met a man and they started dating and they got married. Lo and behold, she had a baby back in, this was now 2004, I believe. She had a child and she sent a really nice letter, handwritten letter with a little baby picture thanking me. Thank God. I was so close to doing a hysterectomy, but it just didn't sit well with me. And now I have this miracle baby, Jalen. And she sent me this beautiful note and picture of Jalen. And I had it up and still have it in my office. And this is now fast forward to a couple of years ago. There was like a knock at the door around 5:30 after we had finished seeing patients, and my front office person came back to where I was doing charts, and she said, "There's someone here to see you." And I'm like, "I thought we were finished seeing patients." And she said, "Yes, we are. I don't know who she is." So I went out, and it was this woman, Ms. Combs, and she said, "You probably don't remember me, but I was the one that had the miracle baby Jalen." And I'm like, "Of course, yes, I remember you." And she said, "Come outside. I want to show you something." So we opened up the door, and out of the car popped Jalen, and he was driving, and he had just graduated high school, and he came with his mom to give me his high school graduation picture. And so I said, "Come on over, come on inside." And so we have this huge bulletin board of baby pictures and other thank yous and other things. And his baby picture was in the on the bulletin board. And I said, "Here, you can put your high school graduation picture next to this handsome guy." And so now they're both there. And it's very gratifying. And it's the fuel that keeps me coming to work every day. I can't imagine doing anything else.
No, I love that. And the fact that, it didn't sit well with her. And she said, you know what, I'm going to get a second opinion. And I think
That's
that's
so
really important
important.
in healthcare that folks get a second opinion and not just make that decision right then and there, even though sometimes you're in immense pain. But
Right.
you just never know, like getting a second opinion can really help and change your life. And this is a prime example of how she did that. And then now she's a mother.
And she said, "I was this close." She was holding her fingers. "I was this close to getting a hysterectomy. And if I would have listened to my gynecologist, I never would have had my miracle baby Jalen." I'm so grateful. And that is important because when you're suffering so badly, like a lot of women with fibroids do, it's hard to make, rational decisions because you're just suffering and you want the suffering to end. And so you've got to get that second opinion, and listening to your body, listening to your inner self is really important. As you mentioned, you're the CEO of your own body. You know your body better than anybody else, including any doctor. And so if something isn't sitting well with you, or if you feel like your symptoms are dismissed or not taken seriously, a lot of our patients relate stories like that because they're bleeding heavily and they go to their gynecologist or primary care physician and they're left with the impression that that bleeding is just part of being a woman. Um, or they won't get treated unless they have a certain low hemoglobin. And it's just ridiculous. I tell patients, if you're bleeding, your menstrual period, if your bleeding is such that it's impairing or affecting your quality of life, it's not normal. It doesn't matter how long you've been doing that. Because a lot of women have been bleeding very heavily for a long period of time, and they assume it's normal, and their doctor kind of just puts it off as, well, you're just happen to be a heavy bleeder. No, you're hemorrhaging. That needs to be treated. It's not normal, no matter how long you've been doing it.
Wow. No, I really appreciated saying that um it can start becoming a norm for you because this is all you've known
Right.
from young, from whenever you started having, your period. So that's really important and to know, and then also that they are hemorrhaging. Is a really great perspective. And I also wanted to tie in too. So you have achieved fellowship status in both the American College of Radiology and the Society of Interventional Radiology, honors held by a small percentage of physicians. What does that level of recognition mean to you, and how has it expanded your ability to advocate for women's health equity?
Well, it's the honors are really nice. Those two particular honors are given by my peers. And so it's especially gratifying to be recognized by other physicians, other peers. And so, yes, that is, I'm in rarefied air being in both of those, being recognized by both fellowship in both of those uh, situations. That's very nice. But what is even more gratifying is trying to get out and educate women that they don't have to undergo major surgery to treat their fibroids. So my particular life's work happens to be in that vein and in educating women get that second opinion, as you mentioned, that's so critical because what's happening now is when women that are suffering with fibroids go to their physician, they're only hearing the surgical option because the gatekeepers of women's health, the gynecologists, they're all trained surgeons. And so if you're a surgeon, a lot of time, not everybody, but most surgeons will only mention the surgical choices, myomectomy and hysterectomy. They won't mention UFE, even though the American College of Obstetricians and Gynecologists back in 2008 endorsed UFE as a safe and effective option for treating women with fibroids. So even though the procedure itself started back in the mid to late 90s, and it took the American College of OBGYN till 2008 to recognize it, now we're in 2026. There's no excuse for women not to know all the treatment options, not just the surgical ones. UFE is one of the biggest medical breakthroughs for women suffering with fibroids. In terms of significance in the women's health sphere, I would put UFE up there in terms of significance with the pap smear and the mammogram. That's how significant UFE is. And yet, most women struggling with fibroids never get the opportunity to hear about it. So I really appreciate coming on your podcast. That's going to help women to understand and learn about UFE. I spend a lot of my time out of the office at lectures and podcasts and other conferences trying to educate the lay public as well as physicians, where we speak at gynecology and primary care physician conferences too. Physicians need to be educated as well as the public.
No, definitely. I love how you touched on too, like also like educating the public, but also inside of with your peers, with other physicians, so that they're aware. And as you said, like the timeline, um, it started in the late 90s and then just recently became recognized in 2008. So I think there's like still a lot of catching up to do.
Wow.
So I love that you're like still actively trying to make sure that other medical doctors are being aware, like, hey, it's recognized, it's safe, and make sure that your patients have that option. Don't just keep pushing surgery.
Yeah, I mean, as a number of things in science and medicine, the procedure was discovered entirely by accident. We had been embolizing cancerous tumors for many years prior to the mid 90s when somebody got the bright idea in France. Why don't we embolize women suffering with fibroids? The tumors are vascular in a sense like the vascular malignant tumors. If you cut off the blood supply to these tumors, it'll make it an easier hysterectomy. And so a group in France started doing embolization for fibroids prior to their hysterectomy. Well, in this country, when we embolize a cancerous tumor, they just go right to the operating room the same day. But in France, which is socialized medicine, rationed healthcare, because the hysterectomy is not something, it's not an emergency, it's not trauma or something emergent, they got the embolization done, but then they were discharged from the hospital and had to recover. And then they waited for their elective hysterectomy, which in France, because it's socialized healthcare, you wait quite a while to get something elective. They were waiting 6 weeks, 7 weeks, 8 weeks to get their elective hysterectomy. Well, during that 6, 7, 8 weeks, what happened to those women? Well, their symptoms went away. They were embolized and their symptoms got a lot better or went away completely. So they called all these women were calling their gynecologist in France. I feel great. My symptoms are gone. Do I still need that hysterectomy? And when they looked at it, the answer was no. You don't need the hysterectomy. You don't need that second part. All you need is the embolization. And so the group in France that did the first embolizations in the world back in the mid 1990s, they called the UCLA. I guess the gynecologist had a good friend who was worked at UCLA, was a chief of OBGYN at UCLA. And he said, "You better get the interventional radiologist at UCLA on this. This is pretty exciting." And so Scott Goodwin, who was the chief of interventional radiology at UCLA at the time, he did the first 11 patients in the United States with this UFE procedure. And he was presenting his data at a medical conference, and I was presenting on embolization of these malignant tumors we were doing here in Atlanta. And I listened to Scott's speech and I'm like, wow, I'm in Atlanta. I could help so many women if this is as they say, and it clearly was and is. Um, and I just dedicated my life to doing that procedure and caring for women with fibroids. And now we've done more UFE than anyone in the country. I've done more than 10,000 UFE procedures. It is the largest experience in the entire country, and it's what keeps me going every day. I hope I can continue to do this for a long time.
No, I really appreciate the work that you do. And to be able to say that you've served over 10,000 women is amazing. And it's so critical that they're getting that support that they need and avoiding surgery. So I also wanted to kind of tie into, so like you've served on multiple boards, including the Medical Association of Atlanta, the Cobb Country Medical Society, the Outpatient Endovascular and Interventional Society, and as president of the Southeastern Angiographic Society. How have these leadership roles shaped your understanding of system level change in medicine?
Well, I say I've been on a number of medical boards, and it's important, to be on those boards and to try to. It's medicine is a very hard ship to steer. People get pretty set in their ways, and change is hard for people, and it's also takes a long time. It doesn't move quickly, but it's important to be at that table and to have those conversations with other physicians. That's so vital. But what I think I'm as proud of or more proud of our clinical success and being in the medical boardrooms. Um, I'm also on the board of Hosea Helps Feed the Hungry. And I had the privilege of knowing Hosea Williams, who started Hosea Helps Feed the Hungry here in Atlanta. And his daughter and son in law have taken the mantle and now run the organization. Um, and so I am on the board there. And to see the work that they do in our community, not only to those that are hungry or food insecure, there's so much more. In fact, they kind of changed their name to Hosea Helps because it's more than they do more than just feed. They provide support for rental assistance. They provide energy support. They provide resumes and work, trying to get people jobs and housing and you name it. I mean, they're just angels in our community. So while I am proud of the clinical stuff that we do, I think the board that I'm on that I'm most proud of is the Hosea Helps board.
No, I love that. And I think it's like really important, like being able to like volunteer your time back and being in those rooms and spaces and using your voice to advocate for those that can't advocate for themselves. Um, so like also too, like what responsibility do professional medical societies have when it comes to addressing disparities in care, particularly for conditions like uterine fibroids that affect women of color?
Well, I think we have a significant responsibility. One of the things that um, is disappointing is that Georgia is one of the states that declined government expansion of Medicaid. Um, and that was disappointing. And we've tried at the medical society level to meet with political figures to try to change that. There are so many people that are needing assistance, not only in food, but also in healthcare. And to turn down essentially money from the government, which didn't cost our state anything, is disappointing because people could use that. And there's such a need. Um, so we continue to fight that battle. And as I say, it's not an easy one. With fibroids, there is a legislation, the Stephanie Tubbs Jones Fibroid Research and Education Act, that is sitting dormant in both the House and the Senate. Stephanie Tubbs Jones was in the House of Representatives, and she suffered with fibroids. And unfortunately, she passed away before her legislation could get passed. But what it does is two things. It directs the CDC to educate the public and physicians on fibroids in general, but also these um, alternatives to surgery like UFE, like the uterine fibroid embolization procedure. That's an important piece of it. And it also provides much needed research. It provides $30 million a year for 5 years to really look at fibroids and try to figure out where fibroids come from. I mean, the lack of research is really appalling. Fibroids, we don't know where they come from, but once they arrive on the scene, they grow with estrogen. That's why they can grow rapidly when a woman is pregnant and why they tend not to be an issue for most women once they reach menopause. But we should know where fibroids come from. But because there's been almost no research money in the fibroid arena, I mean, if to take an example to show another example of a health inequity, of which obviously there are many, but roughly $18 million a year is spent in fibroid research, which might sound like a lot of money, but in the research game, if you will, that's peanuts, particularly when it affects so many women. I mean, at least 80% of African American women have fibroids. It's estimated that 30 million women have fibroids. So if you do the math, it comes out to about 69 cents per individual that's affected with fibroids. And it's also has a huge effect. Every year, there's about a $30 billion cost to society from the effects of fibroids. So it's not only a very common issue, but it has quite an effect and causes a lot of financial hardship, if you will. If you take a condition that affects primarily Caucasians, cystic fibrosis, which affects only about 30,000 people, not 30 million people like fibroids, it garners $94 million a year in research funding, which is $3,000 per person affected. And cystic fibrosis, while it's an unfortunate condition to suffer with, doesn't have anywhere near the impact that fibroids do. So not only does it not affect as many people, it doesn't have as significant an effect to society as fibroids do. So you have a condition that affects primarily Caucasians, garnering $3,000 per person affected, versus a condition that affects African American women or women of color getting 69 cents per person affected, for a condition that affects so many more people and to such a greater degree. I mean, it is tragic.
No, it is. And I also kind of wanted to touch on to that point too. Like many women are told that hysterectomy is their only option. So from your perspective, why has uterine fibroid, um, this really critical service that you're providing, not been more widely presented as a first line treatment?
Well, it's there's a number of reasons. One, the gatekeepers of women's health, the gynecologists, are all surgeons, and surgeons love to operate on people. And so they conveniently don't mention it as an option. They only mention the surgical options because they like to do surgery. There's also a uglier side of this, if you will, kind of a carryover from, I'm in the South, and the South has a pretty ugly history in how they've treated African American women and women of color. Um, whether you talk about the Fannie Lou Hamers, the Mississippi appendectomies, the experimentation on young Black women. Um, so there is some of that carryover, um, just a lack of respect for these women, and there's an equal amount of mistrust by women of color um, towards their healthcare provider, and so that's a difficult thing. It's very unfortunate, and it's something that we talk about a lot, and we work very diligently um, to overcome, if you will, because obviously I'm a white male physician practicing in the South in the midst of this very tragic, unfortunate history. And it's something that I'm presenting an alternative to hysterectomy. And so people have to first kind of trust you. I mean, once I think they see that you care about them, I think that's when the trust begins. And I've been very fortunate at the Atlanta Fibroid Center, where we have seen women from all over the country come for our expertise, even other countries. And the vast majority of my practice are women of color.
No, I really appreciate that, especially touching on like um the history of the South and how that has played a part and how it is carrying over, and how physicians located in the South are still treating women of color um, not the best. So, also, too, you've spoken openly about the amputation of women of color um, for began disease. Why is this important to name that reality directly?
Well, I think when women hear hysterectomy, they don't really, I think, understand what happens to women when they lose their uterus. The uterus is very important. Um, in fact, there used to be a condition tied to the uterus called hysteria. It was a condition only women got, and they felt that it was emanating from a woman's womb. And so the origins of hysterectomy really come from hysteria. When women were labeled with hysteria, originally they were sent to asylums. And then when hysterectomy came on the scene surgically, they began doing hysterectomies, removing a woman's womb, thinking that would cure their hysteria. It's known now, obviously, hysteria is not a real, that is not a real medical condition. It was really a way of control, and it's uh, outdated, completely outdated. But that's where the origin of hysterectomy came from, and it kind of then emanated to this country, where people started doing hysterectomies for all sorts of conditions and unnecessarily removing someone's uterus. Um, and we now have a much better way of treating a real condition, fibroids, which are real benign tumors of the uterus, don't have to have a hysterectomy. The UFE procedure is safer, it's less invasive, the recovery is much shorter, and importantly, you get to keep all your parts because when you lose your uterus, it changes women in all sorts of ways, psychologically, sexually, urinary leaking, bone loss, as we mentioned. It's just unnecessary. It is an option, but it should be the option of absolute last resort because UFE is so good.
No, I really appreciate you reiterating that again, like that it should be the last option. It should not be the first option. And saying like this is it. Why? And if the patient does not want to do it, still trying to push that onto the patient. Um, so and like even also too like in this episode, it's a part of our like Men in Medicine series. So what responsibility do male physicians have when it comes to advocating for conditions that primarily affect women?
Well, I think it's really important to listen to your patients and not to dismiss or ignore what you're hearing. I mean, too many physicians, male and even female physicians, when treating women suffering with fibroids, can be dismissive or that's your lot in life or you're exaggerating. Um, you need to listen to your patients. They know their bodies better than anybody. And when they're having specific complaints, whatever it is, you need to listen and try to figure out why this is happening. And so when patients come to us complaining of heavy periods and pelvic pain, and it really sounds like it's fibroid related, we'll use imaging as well as the examination to kind of put it together. Oftentimes these women, their uteruses are enlarged like a pregnant woman, and so they'll be described as having a certain pregnant size uterus, even though they're not. Nobody wants to look pregnant when they're not pregnant. That can be um, pretty embarrassing for both parties, but they will. Women suffering with fibroids often have an enlarged uterus, and that will be a tip off that that's what's causing the symptoms. But we'll also use more sophisticated imaging. They may have had a pelvic ultrasound with their gynecologist, but we use what's called magnetic resonance imaging, MRI, which is much higher resolution than ultrasound and really gives uh, a very important three-dimensional picture of what's going on, way better than the ultrasound that they've obtained with their gynecologist. So we'll listen to their symptoms and we'll look at the imaging and see that hopefully that it fits. And if their symptoms are due to fibroids, it's something I can help them with the UFE procedure.
No, definitely. And I love how you like said that it's important that they're getting that help and support that they need. Um, and then also like always tying it back to listening to the patient and their needs and not trying to push for surgery. I think like again is like the overarching theme here. And also how can men in healthcare use leadership positions on boards and societies and institutions to actively dismantle inequities rather than unintentionally reinforce them?
Well, you got to speak up. I mean, if you don't say anything, then how is something going to change? So um, you've got to speak up, and we try to use whatever platform that we have available to us to educate the public, to educate our, colleagues, our physician colleagues. As I say, I speak at gynecology conferences talking about UFE and the importance of educating about all the treatment options. And we do the same. When I see a patient, I not only mention the UFE procedure that we do, but we also talk about the surgical options. And sometimes the surgical options may be the route that the patient wants to take, or maybe the better way to do it is with the surgical approach. But it's important that all the options are discussed and that the patient decides what option is best for her.
No, I think that's really important too. Like again, making sure that she is being the decision maker in that process and working together, and making sure like not doing unnecessary surgery. Um, so also too, fibroid research receives disproportionately low funding compared to other conditions. So what does that say about whose pain is prioritized in medicine?
Well, as we talked about the example with cystic fibrosis and fibroids and the marked difference in funding for these different medical conditions, it's very unfortunate. It's just another example of a disparity in medicine that really needs to be corrected. And I'm hoping that the Stephanie Tubbs Jones Research and Education Act does get uh, passed. We need some more signatures from the Republican side. So far, Democrats are the only ones to have signed on to this bill. It's Representative Clark from New York, where I'm from originally. She's championing the House of Representatives side of the bill, and Cory Booker from the Senate side. But I've spent some time trying to speak to some Republican senators and Republican members of House to try to get their signature on it. I mean, um, Senator Scott from South Carolina is an African American gentleman. There's no reason why his signature isn't on there, um, and many others. Even you don't have to be someone of color to put your signature on there. You don't have to be a Democrat to have your signature on there. This should not be a partisan issue at all. This is really important funding for something that affects 30 million people, a tenth of the population. It's something that should garner attention and should not be partisan whatsoever.
No, definitely, it should be a coming together moment.
Yes.
He said it shouldn't matter if you're a Democrat, if you're a Republican, just being sure that we're coming together and creating more access for this specific issue is really critical and important. And I like work in research, and I'm a current PhD student, so I know how important it is to have funding to support the work that you're doing. Um, so I love that you like how you explain that. Um, and also like touching more into like that advocacy component, several high profile women have publicly shared their experiences with UFE. How powerful is patient storytelling in shifting medical culture?
I think it's very powerful. I mean, Cynthia Bailey was a patient of mine, along with Portia Williams. Um, we've had a number of high profile athletes, um, Olympic medalists, and whenever um, these women come forward and tell their stories, it's very meaningful because it really does move the needle. Um, and I can mention those names because they've gone public with their stories. And, um, whether it's Teresa Edwards, the Olympic athlete, or whether it's Cynthia Bailey from the Real Housewives, whoever it is, they have a large platform of people that follow them. And when they tell their story, so many other women who've been suffering say, wait a minute, that's me. I was suffering like that. You mean I could have UFE, and I need to know more about this UFE procedure that you had that gave you your life back. I need to know more. And it's been so helpful when these high profile people with large platforms that have firsthand experience, not only suffering with fibroids, but getting the relief with UFE. When those come together, it's very powerful and can finally, I'm hoping soon, um, there'll be a day when everybody knows about UFE so that we don't have to constantly have to advocate for it. It'll just be a known entity.
No, I love that. And I think like it's like you said, they have a high following. So like sharing that story with their followers so then others can be made aware of this procedure and could kind of like move the needle and help in their decision-making process.
Yeah, it
Um,
was very brave of them. I mean, Cynthia was a supermodel, a beautiful woman in fashion, and to take it on as her platform was pretty brave. She was in a very popular reality TV show, and for her to go public with her story about her horrific periods and all sorts of stuff that she was going through, um, you know to her credit, I mean, she was very brave. I mean, I don't think too many people in the beauty and fashion industry would have done what she did, but she brought much needed recognition of UFE to the forefront where people were talking about fibroids, were talking about UFE procedure. I mean, we were on the doctors together. That was an important platform because people watch these kind of medical shows, and um, it was very, very helpful to educate people, and it still needs to this day more education. It's kind of mind blowing how people are still every day in the Atlanta Fibroid Center. I'll see patients saying that they had never heard about UFE from their doctor, and they really need to hear it from the physician. They shouldn't have to go on to Chat GPT or Google or the internet to find out about the treatment options for their fibroids. It should be known.
and I love how you brought up ChatGPT because that is not a reputable source for folks to be using for healthcare decision making. Um, And like also too, like, so what would you say directly to a woman who's been suffering silently with fibroids and feels dismissed by her providers?
Find a new provider. Um, if you're being dismissed or ignored, there are plenty of good physicians, no matter what community you're in. Find someone that you trust and that will listen to you and will help you and provide you all the options for treating fibroids. Hopefully, they'll also mention UFE, uterine fibroid embolization, so that you know all the options, not just the surgical ones, and you can pick the option that is best for you.
No, I love that. And really making sure that they're, again, like being their own advocate, and picking what's best for them and knowing that they don't have to get a hysterectomy. They can have other options that are safe. And also, too, if you could change one thing tomorrow about how fibroids are treated in this country, what would it be?
Well, that every woman knows about the UFE procedure. That's the mission. We want to stop unnecessary hysterectomies for fibroids. I mean, fibroids are benign tumors. You don't need to do an amputation for benign disease. The UFE procedure is very simple. As I mentioned, it's a 30-minute outpatient procedure. The approach and how we do it is where the right leg meets their torso, we can enter the body. If you push down there, you can feel your own pulse. That's the right common femoral artery. That's the artery that we enter. And I advance a little tiny catheter like a piece of spaghetti, and I can steer it into each of the uterine arteries one at a time because there's a right and a left uterine artery on each side of the uterus, and they're like trees. And the trees start branching, getting smaller and smaller and smaller branches. The leaves of the tree are the fibroids. I'm in the main trunk with my catheter in the big trunk of the tree, and I can flow direct these tiny particles to block the tiny peripheral branches that are feeding the fibroid. So the big trunk and the main branches of the uterus stay open. So the uterus is completely alive and normal, but all the fibroids die without a blood supply. Every fibroid, whether you have one or 100, they all die. And as they die, they soften and shrink. And as the softening and shrinking of these fibroid tumors occurs, a woman's symptoms go away.
Wow.
So a
No,
30-minute procedure, we take the catheter out, put a Band-Aid at the top of their leg. They recover at our center for, say, 3 hours or so, and they go home. It's pretty simple. Instead of a major cutting, a hospital procedure, hysterectomy, where they cut the woman open and take out an organ they were born with. And there's all sorts of risks and complication associated with it. And as I mentioned, there's also a lot of after effects. What happens to these women without their womb? And these are typically young women, unfortunately.
no, that's really unfortunate, especially how earlier you touched on that it's a lot of you've seen a lot of young women, younger, like younger than 30s, getting this
Right.
surgery, and that is very alarming. But to like me, what gives me hope is that like you're doing this work, and like really trying to bridge that gap, and build, trust with the community. So I also wanted to ask too, what gives you hope about the future of women's health equity?
Well, I think, the word is getting out and we're becoming more inclusive. There's a lot more diversity. There's a lot more um, women in healthcare. There's a lot more women of color in healthcare. So we're having increasing diversity, I think, is helpful. I spend a lot of time at Morehouse School of Medicine. I'm a volunteer physician at MSM, and I do a lot of speaking there. There's a lot of their residents and their physicians and trainees will spend the day with us at the Atlanta Fibroid Center. And I can see the work that Dr. Rice does there. I mean, she's phenomenal, absolutely phenomenal woman. And they turn out some amazing physicians at Morehouse. And so the future is bright, no doubt about it. And I'm encouraged.
No, I love that. And then also too, how can listeners, patients, providers, and advocates get involved in advancing awareness and reform around fibroid care?
Well, I think they can help us spread the message. And it's really important conversations, talking about periods can be kind of embarrassing, or, I'll hear people say, well, we just don't talk about periods in our family. You got to have those conversations. And I love it when men come to our talks. I speak all over, at health fairs and at church groups and all sorts of community gatherings I'll speak at. And I like it when men are in the room. It's not just women, because men need to know about periods. They have women in their lives. I did a recent thing with the NFL Players Association, and it was a room full of men. But men have women in their lives, and they need to understand what's going on with them. In fact, when Cynthia was going through her struggles, at the time she was married to Peter, and Peter had no understanding about what was happening to Cynthia. From Peter's perspective, he thought Cynthia didn't love him anymore, which was not true, but they were stopped having relations. And the reason why they weren't having relations is because she was bleeding so heavily and having these torrents of blood coming out of her. She was wearing an adult diaper. So when you're bleeding to that degree, you're anemic, you're tired, you're weak, you're fatigued. It's all you can do just to get through the day. Sex is exercise. That goes out the window. Plus, even though you're a supermodel, when you're wearing an adult diaper and bleeding heavily into it, you don't feel very sexual. And so, but Peter didn't understand the first thing about what was going on. And so all he could understand is we're not having relations anymore. She must not love me. Well, fortunately, she had the UFE procedure with me. She got her life back, and she said I gave her sexy back. Because when the periods returned to normal and her iron and hemoglobin levels returned to normal, all of a sudden she had all sorts of energy she hadn't seen in years. She could wear the nice little frilly stuff, Victoria's Secret kind of stuff, and she felt sexual again, and her relations resumed. Um, but it was all about not having that important conversation between those two. So it's important to have these conversations, women to women, mother to daughter, sister to sister, boyfriend, girlfriend, husband, wife, whatever it is. We got to increase the conversations, even if those conversations are, a little messy or a little uncomfortable.
No, and I love that, like how you are also like going and having these conversations with the men and knowing that's important too, because they do need to know, because they do have, like you said, women in their lives. And these men might see them having certain symptoms and not understand why. Um,
Exactly.
but getting that certain like education, showing up to like a seminar or a lecture, um, could really help to bridge that gap, and then like help those women in your life. So I also wanted to say thank you so much for joining us today for the podcast episode. And this episode is a part of the Men in Medicine series because allyship in healthcare matters. So when men in medicine speak up, especially in areas that primarily affect women, it disrupts the status quo and it challenges gatekeeping. And it also helps us restore trust where harm has been done. So Dr. Lipman's work reminds us that advocacy is not outside the role of a physician, it is central to it. Uterine fibroids should not be a life sentence. Hysterectomy should not be the default, and women, especially women of color, deserve full transparency, dignity, and a choice when it comes to their bodies. So thank you, Dr. John Littman, for using your voice, your expertise, and your career to stand up for equity in women's health. If you or someone you love is living with fibroids, know this: your uterus is not disposable, your pain is not normal, and you deserve to know all of your options. To learn more about uterine fibroids and UFE, please visit his website. Also, please get in contact with him and remember, silence protects systems, not people. So let's keep breaking it together. Thank you,
Yeah, I
everyone.
really appreciate it. And our website is atlii.com, atlii.com. And they can even watch me do a UFE procedure on our YouTube channel, which is Atlanta Fibroid Center. So if they go to YouTube and type in Atlanta Fibroid Center, they'll see our video. They'll also see videos with Cynthia and other people that they'll recognize. But it is so important to get that second opinion. And I really appreciate you having us on today.
No, thank you so much. And guys, please check out their website, and please continue to educate yourselves, watch the videos. And it's really critically important that we are coming together and working together, to dismantle the systems and then also, make it you guys more aware. So please, again, visit the website. It'll also be in the description below. And I just want to say thank you so much, Dr. John Littman, for joining us today.
Thanks very much. Appreciate you having me.
Thank you. Take care, guys.